Lauren is one of the senior guidance writers for the VDH Health Information Team, and she is a co-lead of the clinician outreach team for the VDH Mpox response, which is part of what Lauren and Dr. Safri Diawara are part of. She got her education in biology at Williams College. She got her medical degree at Washington University School of Medicine in St. Louis. She had her residency at UCLA and Medical Center, and she got her MPH in epidemiology at University of California in Berkeley. She's previously worked as a medical epidemiologist in communicable diseases at the state and local health departments in California, and was the subject matter expert for various infectious diseases, including several respiratory, foodborne, and fungal infections. And now she can put Mpox as another SME on her. We'll put that next time. All right, with that, I'll hand it over to Lauren.
Thank you so much, Jenny. It's a pleasure to be here in front of you all today. As Jenny mentioned, this is our second Mpox training session. This is actually the one that I'm most excited about. I grew up here in Charlottesville, so it's really nice to come home and to be back in this community. So today, I'm going to start with an overview and some background on Mpox, and then we'll move on to talk about the epidemiology of the 2022 Mpox outbreak. Next, we'll discuss ways providers can collaborate with public health, and then I'll share a few resources. So we'll start with some background on Mpox. Mpox is a rash illness caused by the monkeypox virus, which is an orthopox virus. It belongs to the same group of viruses as smallpox, and it's a zoonotic infection, meaning that it can spread between animals and humans. Now, before the 2022 Mpox outbreak, Mpox was rare in the United States. Most Mpox symptoms are similar to smallpox symptoms, but milder. And the type of Mpox seen in this outbreak is rarely fatal. More than 99% of people who get this form of disease are likely to survive. And Mpox is not related to chickenpox, despite the similar name. So it was first discovered in 1958 in Denmark when there were two outbreaks of pox-like disease in monkeys being kept for research. And the specific animal reservoir for Mpox remains unknown, but African rodents and non-human primates might harbor the virus and infect people. The first human case was recorded in 1970 in the Democratic Republic of Congo during a time of intensified efforts to eliminate smallpox. Monkeypox virus is a DNA virus, as I mentioned, in the genus Orthopox virus, and this genus also includes variola virus, which is the virus that causes smallpox, vaccinia virus, which is the virus used in smallpox vaccine, and cowpox virus. The virus has two distinct clades. They were renamed by WHO experts in August 2022 so that the names would be in line with current best naming practices. Clade 1 is the former Central Africa or Congo Basin clade. This clade causes more severe disease with a case fatality rate as high as 10%. It also spreads more easily, so there can be more person-to-person transmission with clade 1. And clade 1 is classified as a select agent. Clade 2 has been identified in the current outbreak. It's the former West African clade, and historically this clade has caused less severe disease. It's not classified as a select agent. And clade 2 consists of two subclades, 2A and 2B, and clade 2B is the one that's been largely circulating in the current outbreak. Now, in recent years, the epidemiology of Mpox has been changing. Before the 2022 multi-country outbreak, Mpox had been reported in people in several Central African countries like Democratic Republic of Congo or DRC, Central African Republic, and Republic of Congo due to clade 1 virus. And it had also been reported in Western African countries, including Nigeria and Sierra Leone, due to clade 2 virus. In these older reports, human cases were reported mostly from rural forested areas in Central or Western African countries, or in countries with cases related to migration or travel, or in people who had been exposed to infected mammals. And since 2014, the annual number of Mpox cases has increased in Africa. And the reemergence of Mpox might be due to a combination of factors, including environmental and ecological changes, animal or human movement, the end of routine smallpox vaccination since it was eradicated in 1980, improvements in disease detection and diagnosis, and genetic changes in the virus. And from 2018 to 2021, human cases were reported in 6 African countries, and DRC and Nigeria reported the most clade 1 and clade 2 virus, respectively. Now let's transition and talk about Mpox cases here in the US. So cases in people outside of Africa were typically linked to international travel or imported animals, but these were not common. In 2003, however, there was an outbreak of 47 confirmed and suspected Mpox cases from 6 Midwestern states. All people that were infected in this outbreak became ill after having contact with pet prairie dogs. And the pets were infected after being housed near imported small animals from Ghana. And this was the first time that human Mpox had been reported outside of Africa. The investigation found no infections were caused exclusively by person-to-person contact, and there were no additional reports of Mpox cases in the US until 2021, when there were 2 travel-associated cases that were reported. And both of those cases had recent travel to Nigeria. CDC and state health departments investigated those cases, and no further cases of Mpox were identified in the US. Now we'll move on to discuss the current 2022 multi-country Mpox outbreak. In early May 2022, UK health officials announced a confirmed Mpox case in a person returning from Nigeria. Additional Mpox cases were identified in the UK, and some occurred in people who had not traveled to an endemic area or had a known epidemiologic link to other cases. The number of Mpox cases rapidly increased and expanded to other countries. And it was noted that these cases were occurring primarily among men who have sex with men. The first US case was reported on May 17, 2022, in a Massachusetts resident. And on May 23rd, CDC launched an emergency response that emphasized surveillance, testing, medical countermeasures, and education. Additional cases were reported in the US, and the first presumptive Virginia case was reported on May 26th, and it was confirmed by CDC the following day. Cases to date have been reported in all 50 states, Washington, D.C., and Puerto Rico, and all cases have been from clade 2, specifically clade 2B. The World Health Organization declared the Mpox outbreak was a public health emergency of international concern on July 23rd, 2022. And this meant it was an extraordinary event that posed a public health threat to other nations through the spread of the virus and required a more coordinated international response. And that WHO declaration ended on May 11th, 2023. The 2022 Mpox outbreak has been unprecedented with its worldwide spread and its emergence of cases in countries that had never reported Mpox before. It was the first time that there was sustained person-to-person transmission, primarily spread through sexual contact. And this figure shows the distribution of Mpox cases around the world. Orange dots represent countries that have not historically reported Mpox, and the blue dots represent countries that have historically reported Mpox. Larger dots, like the one seen over the US, indicate a greater number of cases reported from that country. And as of December 27th, more than 92,000 Mpox cases have been reported from 116 countries with 171 deaths. This figure shows the epi curve by month for cases from July through December 2023. And as of that date, the majority of cases reported in the past 6 months were from the Western Pacific region, represented in this figure in green, followed by the region of Americas in blue and the European region in red. 96% of cases with available data are males with a median age of 34 years. Males 18 to 44 years old make up 79% of reported cases, and sexual encounter was the most common transmission event. For cases with information available, 85% identified as men who have sex with men. 52% of Mpox infections were in people with HIV, but these data were not available for the majority of cases. During the outbreak, the US has had the most Mpox cases of any country, with more than 31,000 cases across all 50 states, Washington, D.C., and Puerto Rico, and 56 deaths, with 2 of these deaths being reported here in Virginia. This map shows U.S. Mpox cases by state, with the darker shade representing states with more cases and lighter shade representing states with fewer cases. The hardest hit states have been California, New York, Texas, Florida, and Georgia, and Virginia ranks 13th. We have had 579 Mpox cases in Virginia. In the US, the total number of new Mpox cases has been trending downward since late August 2022. However, there's variation based on state or region. So CDC does continue to urge health departments, clinicians, and the public to remain vigilant, to institute appropriate infection prevention and control measures, and notify public health authorities of suspected cases to reduce disease spread. The epi curve in the top right shows all US Mpox cases, and there is a distinctive peak in cases that occurred in the summer of 2022. In the center, we can see all of the cases reported in 2023, which are the blue bars, and the 7-day moving average of daily reported cases, which is the orange line. The average number of new cases has fallen from more than 450 a day in August 2022 to between 4 to 8 a day as of December 2023. In the spring and summer of 2023, 2 jurisdictions, Chicago and then Los Angeles, reported an uptick in cases, and several other US jurisdictions, including San Francisco, San Diego, and Oregon, have also reported smaller increases in cases. And these increases in cases in multiple locations serve as a reminder that the outbreak is not over, and we must continue the work to prevent Mpox transmission. This figure shows US cases by age and gender, and you can see that the overwhelming majority of US cases are in men, represented in the figure in dark blue, and most cases are within the age range of 21 through 55 years. This figure shows distribution of cases by race and ethnicity in the US. In the early stages of the outbreak, cases were primarily occurring in non-Hispanic white men, seen in the figure in dark blue. But as the outbreak progressed, we saw increasing number of cases in non-Hispanic Black or African American people, seen in the figure in orange, and Latino or Hispanic people, seen in purple. Disparities have been observed in this outbreak, as Mpox has disproportionately affected racial and ethnic minority groups. When we look at the overall race and ethnicity data in the US, we see a nearly equal distribution of cases, so that about 1/3 of cases identify as Black or African American, 1/3 identify as Hispanic or Latino, and 1/3 identify as white. Last May, CDC authors published a summary of the domestic Mpox response so far, and they described the epidemiology of the outbreak as well as the public health response. The authors reported the majority of cases have occurred in adult men who have sex with men and in people aged 21 to 55 years old. And similar to what was seen globally, here in the US, the outbreak has also disproportionately affected people with HIV. 38% of US cases were in people with HIV. And as I've mentioned, health disparities were seen with racial and ethnic minority groups. Black and Hispanic people were disproportionately affected by Mpox infection, and the majority of deaths were in Black people. Further, 94% of the people who died were immunocompromised because of HIV infection that was poorly controlled. And these data highlight that there's overlap with Mpox and HIV infections, and both epidemics are interacting with each other. It shows the importance of integrating Mpox into routine HIV and other STI care. And these data also demonstrate that there needs to be a focus on equity when addressing Mpox prevention, education, and access to vaccines and treatment. Let's look at some of the data in Virginia. This figure shows Virginia's epi curve. As of January 30th, yesterday, there have been 579 confirmed cases, 32 hospitalizations, and 2 deaths. Based on the epidemic curve, newly reported cases peaked during the week of August 7th to 13th, 2022, with an overall downward trend since then. Most of the cases were reported in the northern region, followed by the eastern and central regions, and southwest and northwest regions reported the fewest number of cases. Since January 1st, 2023, there have been a total of 13 sporadic Mpox cases in Virginia, and the most recent case was reported in the week ending January 16th. And in Virginia, we have not seen any clusters of Mpox cases as some other jurisdictions have had recently. This figure shows Virginia cases by sex. The majority of cases in Virginia have been in males. And this figure shows cases by age group. Cases have been predominantly in the middle age groups, with the most cases in adults in the age range of 20 to 39 years. And this figure shows Virginia cases by race and ethnicity. You can see that Blacks make up the majority of cases, followed by whites and then Latinos. VDH has taken action to contain this outbreak as quickly as possible, and this slide illustrates some of those actions. So VDH asks healthcare providers to immediately report suspected cases to the local health department, even if testing is being conducted at a commercial lab. VDH investigates all reported suspect cases and facilitates testing at the state lab or DCLS if indicated. Close contacts are identified by the LHD and monitored, and the local health department also provides counseling to close contacts about post-exposure prophylaxis or vaccine, and the importance of quickly seeking care if they develop symptoms. And lastly, wastewater testing for monkeypox virus has been performed in Virginia. These next few slides focus on Mpox spread and its clinical features. Now, Dr. Shishida will also be going into depth on these topics in his upcoming presentation, so I'll just give you the highlights from these slides. So the incubation period ranges from 3 to 17 days, and it's been on average 5 to 6 days. Most of the spread in the current outbreak has been from close personal, often skin-to-skin contact, including sexual encounters with another person who has Mpox. And while most of this spread has been from male-to-male sexual contact, cases in this outbreak have also occurred due to contact within households, heterosexual sexual contact, and sharps injuries, say due to a needle or scalpel. And many cases so far have been in people who identify as gay, bisexual, or other men who have sex with men, but I want to emphasize that anyone can get and spread Mpox through close contact. So I'll just highlight that the presentation of symptoms in the 2022 outbreak has been different than what was previously seen with classic Mpox in older reports. So the rash in the current outbreak has frequently been located on mucosal areas, including the genitals, in and around the anus, or in the mouth. And also we've seen rash lesions that are localized to one area of the body, and the rash lesions have not always been in the same stage of development. And again, Dr. Shishida will be discussing HIV and Mpox in more detail. I will just remind everyone that in the current outbreak, we have seen that 38% of cases have also been co-infected with HIV. And most reported cases of severe Mpox have been in people who've been living with untreated HIV with low CD4 counts and substantial immunosuppression. CDC has made several recommendations that are listed here, but the highlights are if you have a patient with suspected Mpox and they're sexually active, please test for HIV as well as for other sexually transmitted infections such as syphilis, herpes, gonorrhea, and chlamydia. Consider treatment with Mpox and encourage patients to enroll in the STOMP trial, which is a trial evaluating the effectiveness of TPOXX. Optimize immune function by ensuring people with HIV are on effective antiretroviral therapy, and consider consultation with CDC's team. They're available by email or phone. This slide summarizes some of the infection prevention and control measures for people with Mpox. If patients are isolating at home, it's best if they isolate in a separate room away from others if possible. It's important to try and limit exposure to pets or other people, and don't share potentially contaminated items. They should avoid activities that can spread lesion material and routinely clean and disinfect commonly touched surfaces or items. In the hospital, patients with suspected or confirmed Mpox should be isolated in a single room with a dedicated bathroom. Staff should use PPE, so that includes a gown, gloves, N95 respirator, and eye protection. limit patient movement unless it's necessary for medical care, and if a patient does have to leave the room, they should wear a mask and cover lesions. And then staff should avoid activities that could spread lesion material, such as shaking laundry. Now, while gay, bisexual, and other men who have sex with men make up the majority of cases in this current outbreak, anyone, regardless of sexual orientation or gender identity, who's been in close personal contact with someone who has Mpox is at risk. Now, there are several prevention measures that people can take to prevent infection. Jynneos vaccine is safe and effective before exposure to Mpox or as post-exposure prophylaxis or PEP. And Dr. Dillingham's presentation will go into more detail on Jynneos. I will just highlight that Jynneos PEP is ideally given within 4 days of Mpox exposure to prevent infection or reduce its severity. It can still be effective if given 4 to 14 days after exposure. Other ways to prevent infection include avoiding skin-to-skin contact with people who have a rash that look like monkeypox virus rash. If you're planning to attend a gathering where you might be in close proximity with others, consider the risk. We know that having multiple or anonymous sex partners can increase your chances of getting Mpox. So temporary behavior change, like limiting the number of sex partners, may reduce exposure. And lastly, washing hands frequently or using alcohol-based hand sanitizer can decrease spread. Let's summarize where we are with the current Mpox outbreak. So case numbers, as I've said, they've been declining since peaking in August 2022. And this is likely due to a combination of immunity, both natural and vaccine-induced, as well as some changes in behavior. But despite this decrease in cases, public health continues to monitor Mpox trends and ensure people have access to vaccination and treatment. Since spring and summer of 2023, there have been 2 large clusters of Mpox cases in Chicago and LA, as well as smaller increases in other jurisdictions. And these increases highlight that the outbreak is not over. We need to focus on vaccination of individuals at risk of Mpox, especially in advance of events where people may engage in activities that put them at increased risk. And 2 doses of Jynneos vaccine is recommended for those at risk of Mpox. Now, on November 23rd, WHO released a report about an ongoing Mpox outbreak in Democratic Republic of Congo. And this outbreak is notable for many different reasons. So first, it's an extremely large outbreak with currently more than 14,000 clinically diagnosed cases and more than 600 deaths since January 1st, 2023. Cases have been identified in new areas, including in large urban areas. Second, the DRC outbreak is caused by a different strain of the virus. It's caused by clade 1. And as I mentioned earlier, there are 2 main clades of the virus, clade 1 and clade 2. The 2022 global outbreak has been primarily caused by clade 2, specifically clade 2b. But the outbreak in DRC is caused by clade 1. And clade 1 can cause more severe illness and spread more easily from person to person compared with clade 2 virus. Third, this is the first time that clade 1 virus has been documented to spread by sexual contact, including in men who have sex with men. Other reasons this situation is concerning are stigma against the LGBTQ+ community in DRC and limited or no access to treatment, vaccination, and testing. And this may make it harder to contain spread. In terms of infection control, including specimen handling and waste management, clade 1 Mpox virus is classified as a category A infectious agent and therefore requires more stringent practices than clade 2 and clade 2b. Now, the good news is we don't expect the performance of diagnostic tests, vaccine, and treatment like Mpox to be different between the 2 clades. Overall, WHO assesses the risk as moderate for the general population in neighboring countries and for gay men, bisexual men, and other men who have sex with men and sex workers. CDC is closely monitoring the situation in DRC, and to date there have been no clade 1 infections identified here in the US, and the risk of clade 1 infections here in the US is considered to be low based on the available information that we have. CDC published a health advisory in December to ensure clinicians are aware, though, of the possibility of clade 1 Mpox in people who have had recent travel to DRC. So if suspected Mpox cases have traveled to DRC, for diagnostic testing, follow all regulations for Category B infectious substances. It's important to collect a detailed travel and sexual health history. Contact the LHD to rapidly report the suspected case and coordinate clade-specific testing through DCLS. And it's important to ensure DCLS approval before the shipment of specimens. DCLS is validating its own clade-specific Mpox test, but that test is not currently available. So until it's available, specimens will be shipped to DCLS and then forward on to CDC for their clade testing. We also ask providers to remember to swab multiple lesions and collect 2 swabs per lesion. And for waste management in patients who have traveled to DRC, consider the clinical picture and contact LHD to discuss specifics on how to manage waste. Now I want to highlight some of the ways providers can collaborate with public health during the ongoing Mpox response. While cases and news coverage have decreased greatly, Mpox is still spreading and the risk does still remain. So we ask that providers keep Mpox on their radar when they're seeing patients, continue to promote vaccination, education, and increasing awareness. As Jenny mentioned, we have a lot of educational materials available on both the CDC and VDH websites that you can use as resources. We also encourage providers to integrate Mpox into HIV and STI clinical care and include Mpox on your sexual health checklist. Jynneos vaccine is safe, effective, and it's the best tool that we have to help protect people at risk and stop the spread of Mpox. And we need to continue outreach and education to the populations that are most affected. Vaccine coverage does vary a lot between jurisdictions. CDC published an MMWR last year, and they found that despite the administration of over 1 million doses of vaccine, only 23% of the at-risk population has been fully vaccinated. Now in Virginia, 19% of those at risk have been fully vaccinated, so they've received 2 doses, and 28% have received 1 dose of Jynneos. So we still have a ways to go to close the vaccination coverage gap. If you're a provider and if you're not administering vaccine, please consider doing so. We have instructions available to enroll as a vaccine provider on our VDH Mpox Healthcare Provider Vaccine Guidance webpage. If it's not possible for you to give vaccine in your clinic, we ask that you refer people to CDC's Mpox vaccine locator. And lastly, VDH has quite a bit of vaccine that's set to expire at the end of this year. So now is a great time to plan vaccine clinics and collaborate with community partners and coordinate vaccine outreach events so we can use this existing vaccine to protect people who are at risk. If you suspect Mpox, again, be sure to collect that detailed sexual, social, and travel history for the 21 days before symptom onset. Test for Mpox regardless if the patient has a history of infection or prior vaccination, because there have been reports of people getting Mpox more than once, and there have also been reports of people getting Mpox after being vaccinated. And remember, when testing a patient for Mpox, keep in mind to test all sexually active patients for HIV and other STIs because co-infections are possible and common. And as a reminder, if your patient has traveled to DRC in the 21 days before symptom onset, those specimens should be sent to state lab so they can be forwarded to CDC for that clade-specific testing. Now, if your patient has not had recent travel to DRC, those specimens can be sent as you've been normally sending them. So in most cases, they can be sent to a commercial lab for testing. Providers must notify the LHD immediately if they have a patient with suspected Mpox infection, and we have our LHD locator that's available online to help folks find the appropriate health department. And providers, we ask that you please encourage patients with Mpox to cooperate with the health department. This helps to facilitate timely follow-up, vaccination, and monitoring of close contacts. Here are a few things providers can do for managing patients with Mpox. If you diagnose Mpox in your patient, consider consultation with CDC for questions about patient management, particularly if a patient has a severe infection. We also encourage you to speak with your patients about the STOMP trial, which we'll hear more about later this morning. This is a NIAID-sponsored trial evaluating the effectiveness of TPOXX in patients with Mpox. And patients can participate in this trial even if they don't have severe Mpox or are not at risk of severe Mpox. These are a few ways providers can stay connected with public health. Sign up online for VDH healthcare professional newsletters. You can also sign up online for CDC COCA updates and CDC HAN updates. We have a lot of information available on our VDH Mpox web pages. And we have 2 more of these workshops that are coming up in other locations in Virginia. So please encourage your colleagues to attend these upcoming trainings. And this slide just highlights some of the VDH resources that are available. I just listed out again the websites where you can request printed Mpox materials. There's one REDCap survey for LHDs and a separate one for non-LHDs. And these are our take-home messages. So in general, the risk of Mpox infection for most people is low. The current outbreak has been declining substantially since it peaked in August 2022, but sporadic cases in some clusters continue to occur here in the US. In the current outbreak, most people with Mpox have reported close, sustained skin-to-skin contact, including sexual contact with other people. And the current focus is on awareness, education, and vaccination for people at risk of Mpox. Keep Mpox in mind when evaluating patients, especially if they have a diffuse or localized rash. Incorporate Mpox into routine STI and HIV care. Keep in touch with the LHD to report suspected cases, and stay up to date on the information from VDH and CDC. And I want to thank you for all of the work that you have been doing on the Mpox response, and I'm happy to take a few questions.
We don't have wireless mics, so if you do have a question, please come up and ask your question. I will ask, at our last session, Lauren got hit by a lot of questions, but if you have specific questions about vaccines, testing, or treatment, please hold those for after our next presentations. But please, please, please come up and ask Lauren whatever else you want to. Excuse me, Lauren. Are you aware of any, I forgot, when you come up, please introduce yourself and what organization you're with.
Kim Wetzel, and I'm with HCHC Care Management. We are a Ryan White Part B provider and agency. Lauren, I was wondering if you are aware of any veterinary studies to surveil domestic pets or the presence of Mpox. Specifically those pets who are in the residence of infected persons.
Okay, so I do recall, do you want me to repeat the question, Donald? Does that help you? Okay, so thank you, Kim, for your question. The question was, are there studies looking at domestic pet surveillance, particularly in households of patients who have had Mpox? And I do recall that CDC has been doing some work around that, where they have been collecting specimens on pets to see if they have contracted Mpox. I don't have any further information on that, but that is an excellent question. As far as I know, they haven't detected Mpox in any domestic pets here in the US. But that, of course, is one of the concerns, is that because this is a zoonotic infection, there would always be concern that humans could spread to animals and create more of a severe situation. But as far as I know, there hasn't been that human to animal spread here.
Hey, Ian Rickard, I'm with the local health department. Did you say that we had both clades in Virginia, 1 and 2?
Thank you for your question. And so the question is, have we had both clades, clade 1 and clade 2 here in Virginia? So we have only had clade 2 infections here in the United States. So clade 1 infections have been primarily seen in Africa. And clade 1 infections are causing that very large outbreak in DRC. So the recent alert from CDC was just that there is a possibility of clade 1 infections here in the US, but in terms of surveillance to date, nothing has been seen here in the US or here specifically in Virginia.
Anyone else?
I'm sorry, I already introduced myself. Can you tell us if Jynneos vaccine is equally efficacious against clade 1 and clade 2
Okay.
and 2B?
Okay, so the question is Jynneos vaccine equally efficacious for both clades? And as far as we know, vaccine, testing, and treatment is effective, equally effective between clade 1 and clade 2 infections. And of course, that's something that's going to continue to be monitored with time. But that's a wonderful question. Thank you.
Anyone else? All right, well, thank you.
Thank you again.
Dr. Moore and Lee.